team at Golisano Children's Hospital working in population and behavioral health, and then one of the associate medical directors at Accountable Health Partners focusing on maternal child health. And I want to just start by welcoming all of you who are primary care providers and practice staff and teams, those of you who are child health leaders, behavioral health specialists, and people from all around the Finger Lakes region. And I really want to thank you for giving up some of your evening tonight for what I think is a really important regional discussion. This is being held as a collaboration between Golisano Children's Hospital and University of Rochester Medical Center, Rochester Regional, GRIPA, Accountable Health Partners, the Monroe County Department of Health, and the Monroe County Medical Society. And I think I would just say I'm really proud to be in Rochester. I think it's a pretty amazing thing that we can all come together around kids, and it is a pleasure to see you all here tonight. So I just want to kind of set the stage for the conversation tonight. At the beginning of the pandemic back in March, our goal, all of us collectively, was really to have uniform primary care approaches and consistency in communication for kids. And we want that to continue, right? Especially now while we're in this phase of return to school or return to remote school and hopefully return to in-person school, depending on what district you're in. And we really want to establish a process starting tonight, again, like we did early in the pandemic, for how we can update changes to recommendations so we get it out in a timely fashion to primary care providers, so we can make sure that you guys actually know what's happening in terms of testing and turnaround time for testing. And I think also just so that if changes are occurring regarding state level requirements or other developments, that we can get that information out to you and that we can hear from you about what the impact is actually within the practices. So this is an evening, there will be some presentations, and then there's going to be a lot of dialogue. I would just say that I want to acknowledge right up front tonight that this might not have been the best night to plan this meeting. We couldn't quite tell, like, should we do it last week? Should we do it this week? Should we do it next week? Because we were hopeful that things would be set in stone. We'd know exactly what was happening. Well, it's not. Nothing is set in stone yet. So tonight the goal is to present to you what we do know and then really think together about what we need to do. What do we need to be advocating for? What do we need to be planning for? And how can we support our primary care practices in the best way possible? And honestly, support our kids and our schools. So without further ado, I will just say a couple of things about the meeting. The chat will be open. You've all introduced yourself in the chat, and I encourage people who are still joining in to do so. If you have questions, feel free to put them in the chat. My thought at this point, just to keep things moving for folks, is to let the presenters go through and present the information that we know. Then I will help with Renee Sutton from AHP and our other colleagues at AHP to monitor the chat so that we can bring your questions forward. But we will, once the presenters finish, obviously open this. So if you want to ask a question and show your face at the same time, you're welcome to do so. So our presenters for this evening are, I'm going to list them for you, Stephanie Townsend, who's the Director of Research Analytics at Rock the Future, Brenda Tassini, who's a URMC Pediatric Infectious Disease Specialist and Epidemiologist in Infection Prevention, Kathy Hill-Tunin, who is the Nursing Services Division Director and Manager for Monroe County Department of Public Health, and then Steve Cook, who is part of our general academic pediatric faculty at URMC and is the medical director for the Office of Health Insurance Programs at the New York State Department of Health. The agenda for tonight is basically we're going to go through what the return to school plans are for our region at this moment, and I think they were just updated again today. Stephanie Townsend will walk us through that. We're going to talk a little bit about what the current laboratory testing and capacity is, and what type of testing is approved and manner for testing that's approved for symptomatic versus asymptomatic patients. We're going to look at what the school plans are for symptom testing, or symptom screening, excuse me, for symptom screening within the schools, and then what the current requirements are from the state regarding children returning to school after illness. We'll speak a bit about the role of the County Department of Health, and then we'll also talk about the role for primary care, and then we'll finish the presentations by giving an update about what the recommendations are for masking exemptions. They are few, but we want to make sure that those are stated. So that's the agenda we've set. I'm sorry, I missed, somebody said something. Nope, I'm hearing things. Okay, so without further ado, I'm going to ask for Stephanie Townsend from Rock the Future to just walk us through the wide variety of plans for our region. Stephanie and the Rock the Future and Children's Agenda team have pulled together this great summary document. And Stephanie, if you have trouble screen sharing, we can help you with that. I think it just helps us to realize, as we're taking care of kids from multiple different school districts, this is quite a juggling act in terms of the difference of what's happening. So Stephanie, I'll turn it over to you.
Okay, great. Thank you so much, LJ. I really am very pleased to be here tonight and to have a little time to talk with all of you. I am Stephanie Townsend. I'm a community psychologist. And as LJ said, I'm the Director of Research and Analytics for Rock the Future. For those who may not know who we are, Rock the Future works with over 60 community partners across many sectors to improve education outcomes for Rochester's children. We do not provide direct services or work directly in the schools, but many of our partners do. Our role is to work with all of these partners to help them come up with shared goals, to align their strategies, to have common measures, and to maintain communication across all of these partnerships. So what I have shared here, and LJ will wave at me if you're not seeing it, is a quick overview of the reopening plans in all of the Monroe County school districts. And this includes the announcement that was made just about an hour ago by the Rochester City School District that they are going to begin the year 100% remote for all grade levels, which is a change from what it was before. So that has been noted in there. What you see there then, I did highlight, figuring Rochester was the district that perhaps many of you are most focused on. So they're highlighted in gold there. The big four school districts are at the bottom just as a point of reference, because we do recognize that Rochester, comparing Rochester to a small suburban district or a rural district, may not be a good comparison, but the big four are a good comparison. The numbers in here for each grade level represent the number of days that a child would be in school if they, at the beginning of the school year, under their plans. And so what you see here is that pretty well every school district is opting for a hybrid plan where children will be in school 2 days a week. Most of the school districts, that is a Monday, Thursday, or a Tuesday, Friday schedule, with Wednesday being remote learning for all students. That's not true for every district, but it is true for most of them. And what you'll see there then too is also for special education and English language learners, most districts are trying to provide them more in person. So most of them, that means that many of those students will be in school 4 days a week and only learning at home on Wednesday. The important thing to note, though, for the special education students is that this is not all students with an IEP or a 504 plan. This typically only refers to students who are in some type of specialized class. So a 15-1-1, an 8-1, or any of the other number combinations that denote that there are more teachers or more teacher aides or smaller class size. But your student who simply has an IEP or a 504 is normally in a regular general classroom, perhaps with push-in services, would be following the 2-day-a-week plan of their classmates. So those are some of the common features. The reason I put in red the special education and English language learner days for RCSD is because I have not yet had a chance to go and see their revised plan to know what they are doing for those students. If they are going to be 100% remote like the other students, or if they are going to provide them in-person instruction. I'll have a chance later to go in and see their revised plan. So that's questionable. Likewise, I did go ahead and change the remote, the pre-K to remote for RCSD, but I do need to confirm that. Oftentimes when RCSD makes announcements and they say all of our students, they aren't actually talking about pre-K. So it wasn't clear from the superintendent's initial announcement, so I need to go in and see the actual written plan. So we do have more details. I have a huge Excel spreadsheet with lots of details, including with things like their screening protocols, which you had mentioned earlier. I would say it was probably roughly 50-50 between these districts as to how many were going to have a self-report app that is completed at home before the students come to school versus those who would be doing some type of screening at school. Most of the schools, there are some exceptions, but most of the districts are not taking temperatures at the door, but they are asking that the guardian take their temperature before they come to school and report that through their app. That at least is in what was in their plans. You know, to my knowledge at this point, all of the plans they submitted have been approved, but I don't have verification of that yet. But that is what was indicated to me by one of the superintendents. So I guess the last thing that I'll just say here is obviously, in addition to concerns that you may have about students when they're in school, is where are they outside of school? And that is a big concern of Rock the Future and of the children's agenda. There are obviously major challenges for parents who either are not working remotely or who are working remotely but find it, quite frankly, impossible to do that and supervise their child's school at the same time. So we are starting to see, some of you may have seen reported in the news, there are 2 gyms in Rochester that announced this weekend that they were going to provide weekday programming for children. As well as I saw that the Rochester Museum and Science Center was likewise offering a program, which of course raises some questions and concerns about the whole purpose of a hybrid learning is that we can reduce the exposure of children by reducing class sizes by 50%. But if they are going to another daycare type setting on the days that they are learning at home, then of course that's increasing the number of children that they come in contact with. So I think there's certainly some public health concerns there. I have not heard yet, particularly on the gyms, there's some question as to whether or not they are actually able to provide those programs. So we are monitoring that to find out if there's if the health department steps in any way on those programs that are being offered. So that's what sort of the high level overview right now. I don't want to take up too much time here, but LJ, I didn't know if you wanted to open it up to any questions, if there are any questions coming in, or likewise, if you all have any concerns that you would like to share back with me so that I can take them back to Rock the Future and to the children's agenda, and we can keep those concerns in mind as we continue to work with all of our partners.
Thank you, Stephanie. I really appreciate that. And I can't tell you how helpful it is to have a document like this where this is being pulled together to be able to see. And we appreciate the work of Rock the Future and the Children's Agenda as being staunch advocates for what's best for kids, always. I recognize for those of you on the call who are from counties outside of Monroe, we have not represented every single school district in the Finger Lakes region. I'm sure that you guys are in contact with the schools within your catchment area for your practice, but at least this gives some level setting in terms of what's happening for most. The news about RCSD, I didn't hear about it until 5 minutes before this call. I'm still kind of reeling from that. So I think a lot of people are, and you know, all I will say is we've got work to do to make an impact in this area of disparity for our kids. So with that being said, I'm gonna have somebody else speak, and Brenda Tassini, I'm wondering if you could step in at this point and just give us an overview about sort of the current laboratory testing, what the approved testing processes are, what the right platforms are for testing, and I'll give that to you, Brenda. I can't see you on the screen, but I know it's somewhere.
Yep, I'm here now. I think I've got my video back on. So hi, everyone. I'll give a really kind of broad overview of diagnostic COVID testing in general and in our region. So the basic process would be respiratory samples for PCR testing, and I think that's the first kind of branching point. Is that's the most sensitive test, and there's a lot of discussion now about antigen versus PCR testing, which we can get into in the end if there's time, but that's really the highly sensitive test. And what our two local lab systems that run tests locally are performing. So for the URMC system, we're requesting a deep nasopharyngeal swab for symptomatic patients. And if it's in a more asymptomatic screening format, and particularly kids in a situation where they might need repetitive testing, it would be okay to do a nasal turbinate swab. That's also another accepted specimen. And the big question is, how many tests do we have? What is our capacity? And in the region, we have capacity to run in the thousands for our whole community, and that would be done locally with a quick turnaround time. Otherwise, testing can be done at any level, but as we're hearing around the country, these labs get funneled to a few central labs with turnaround time not quite guaranteed. So both of our main lab systems here do have the ability to run tests locally, and they each have different avenues to get into that system. And I know for the URMC labs, there are lab sites that will perform the testing with the doctor's order, and urgent cares will perform testing from within the system with the doctor's order in the system. And RRH has other funneled ways to get in the system, and some of the independent urgent cares also have testing options available through them. I think I'll probably leave it at that level for now, unless LJ would like to get into more details now, but that's the 30,000-foot view.
I appreciate it. And I think that the question that people will have is, in terms of commitment to increasing testing, recognize now we're going to be testing a group of patients who really weren't on the radar screen for testing before.
Yeah, and I know every lab system is trying to figure out how can they get more tests. Everyone certainly wants to be able to test everyone, symptomatic or not, who personally feel or their provider feels they need testing. I can tell you that throughout the pandemic, we've had various times when it's been more stressful than others in trying to meet the testing needs. And we've really always been able to, you know, within a week or two, get that increased capacity. I don't know how. I think the lab directors here are amazing. And when the need has shown to be persistent, they've been able to squeeze resources using, you know, several platforms and doing testing on their own in both of the labs to be able to meet the needs. So I don't want to sound overly optimistic, but I've been very pleasantly surprised at how the labs have been able to meet the continually increasing demands. So I'm hoping that this will be another one of those situations. And it does sound like by winter time, I have next calendar year, everyone is expecting a real massive increase on the national level in terms of availability of supplies in large volumes. So these first few weeks, I think we're all just going to have to see together what the demand ends up being. And I would expect to see a corresponding increase in capacity. But the first couple of weeks, I think we're just going to have to work together to see what that ends up looking like.
Thank you, Brenda. If I can ask you one more to speak to. I know that we've been contacted by some of our practitioners who have been looking at purchasing antigen testing, you know, for point of care testing in their offices. And I was wondering if you could speak to that.
Yeah, certainly. And that's I think a very exciting and appealing option. Unfortunately, the commercially available antigen tests now, there are 3 or 4 that come to mind, major platforms. The sensitivity of the tests all fall around 80% if you compare it to a PCR test. So less than ideal, right? So a kind of unacceptably high rate of false negatives. So it's recommended that a negative antigen test be confirmed by a PCR. So there's a role for it. Certainly a positive antigen test, you would immediately isolate the child, treat them as positive. A negative test is recommended to back up, and I would support that recommendation to back it up with a PCR. So those kids would still need to get eventually a PCR either sent out to a national commercial lab or one of our local labs.
Excellent.
So probably an expensive
so not a wise investment format. At this point, realistically?
I think, and certainly with our current rates, you know, majority of kids will test negative and hopefully we'll be able to keep it that way. So to need to then do a confirmatory test on all those kids, I think is it's just not its time yet. Pretty similar to flu rapid antigens that I think we're all a little more familiar with.
So I'm seeing a bunch of questions coming into the chat about testing specifically. So I think we're going to take those right now. And I think Stephanie and others have answered some of the other questions coming about schools. So if you guys are watching the chat, you're seeing that. But testing specifically, Chad, you responded to a question about when can you use a nares or a mid-turbinate swab? And it is really only for asymptomatic testing. Am I clear on that, Brenda?
That is if it's going through the UR labs, that's our URMC protocol and recommendation. Yeah, so that follows that. In general, it's a little less sensitive. How less sensitive? Jury's out. There are a lot of different studies, you know, talk about scientifically, but yes, through our labs, that's been kind of our cutoff.
I just saw that the question that just came through right through here, and then I will turn it over to you in 1 second, was about, are the schools considering or the labs considering doing pooled batch testing?
It is that's another hot topic.
I know.
Certainly are considering it. if that would be an option if we can't increase our capacity to meet the demand. I think if we can, the ideal would be to just increase capacity to meet the demand. Much like the difference between, you know, the deep NP swab versus mid-turbinate versus nares versus oral, you're losing sensitivity each time you do that. You're losing sensitivity each time you pool, and really depending on how many are in the pool. And logistically, they have to get pulled together. They have to be able to be tracked together. You could devise a really great system to do that with schools, but I mean, that alone would require a team of people at each school to logistically do that. So I don't think anyone in the country, aside from a few colleges, are at the point where they could realistically do that. So it's not off the table, but we're hoping to be able to just increase capacity to meet the demand and continue single specimen testing.
Thank you. And then there were questions about where people could refer patients for asymptomatic testing. And I think that got answered in the chat, did it? But
did you hear that chat? Yeah.
You covered it. Do you want to speak up and just say it? And in case anybody wasn't reading the flying by chat like I wasn't.
So I know for URMC, there's a specific lab site. I don't know what Chad put in there. He might even know some of the
you can unmute. Go ahead, Chad. You get to talk. Go ahead.
Say, so MCC is your best bet for no order needed. If you have a physician's order, you can go to the urgent cares. Some of the private urgent cares will do asymptomatic testing without orders, but it's not ubiquitous. So I would say MCC is your best bet, understanding that the return time for MCC is probably on the order of about 7 to 9 days right now. So it's not going to come back quickly, but it does check the box.
Yeah. And MCC usually wants an appointment also. Call ahead with appointment. It's usually like a couple day delay to get that. So just to warn families.
Thank you for that.
We've got a question about the insurance coverage for asymptomatic testing, LJ. And I want to reassure LJ and everyone else on the call, we'll be, we can send a copy of the chat and the answers that are contained in the chat out to everyone that's participating. So don't want you to panic about anything being missed, LJ.
Thank you. I was starting to have a little rising anxiety as I was seeing like things come through and not able to read and listen and multitask at the same time. So thank you. Insurance coverage. So I think this is a timely question because many of you got the notification from Excellus, so they would not be covering asymptomatic testing. And so we need to loop back around and look at this, because if we're doing contact tracing for schools, which may be asymptomatic tracing, we need to be able to figure this out. So at the moment, that's not every insurer, but I think that the major insurer in town did put out that announcement. So I think more to come. We certainly will advocate for these kids for that to be covered. That's the main thing I would say. And then I also just wanted to say, in terms of the college testing, I do see that Acute Kids put in there that Acute Kids is available for college testing. In Webster, they have been doing a really nice job with that. They have been very helpful about testing in general for our pediatric and college students, pediatric patients and college students. So we appreciate their work very much. So there's a lot of questions coming through the chat right now about like the next topics. So I'm going, rather than going through those questions, I'm going to move it forward, and then we'll come back around if your questions still exist, if that's okay. And so I really would like to move this over to Kathy Hiltunen and then with Steve Cook, who the two of them will be presenting on basically some of the questions you have here about what are the school plans for symptom screening, what happens, what needs to be in place for kids to return to school after they're sent home for illness or they're restricted from coming to school for illness, and we'll go through that. So Kathy, Steve, I'm gonna give it over to you two.
All right, sorry, had another email come in. I want to thank everyone for joining us, and thank Kathy for also helping us out here. I have a couple slides. I'm gonna try to show my screen here if I can get this up right. Come on, there we go, share screen. And Kathy, please jump in
Okay.
To cover all the errors I make here. So a couple of the questions that first came up, can you see the current requirements from the state? Yes, no, maybe? All right, got a thumbs up from somebody.
We can see, Steve.
So basically, kids get sick with COVID symptoms. Schools have to define their criteria, have part of their plan of identifying kids, which is pretty straightforward. We're trying to see if we can give a little more guidance to them in terms of trying to tolerate, symptoms that maybe last more than 30 minutes, as opposed to, oh, he sneezed once, he has to leave, or something like that. But when a kid gets identified with COVID symptoms, they're going to contact the PCP, contact the family, isolate the kid at school, and have the kid leave school. They provider, and this comes in a couple other slides later too, but when it comes back to return to school, it depends on what happens. So if they're actually tested for COVID with COVID symptoms and found to be positive, county health department kicks in. Essentially, that's going to be global for our whole region. We've been working with Monroe County, and they've been great with providing guidance, and it sounds like they're pretty sure the other local health departments are going to be able to do this. So a positive case really gets contact traced by the county health department, and they release them, which is going to need to be at least 10 days from symptoms, or if asymptomatic, if they're tested for some other reason, an exposure or something, it would be date of test. Their symptoms are improved. They don't have to be resolved, and fever-free for 24 hours without antipyretics. Now, obviously, if it's a kid who's getting sicker and needing more help, then they will, that's where we will have to still stay involved with the care. But essentially for COVID positive kids, that's where it'll need to go. Now for...
Steve, I'm going to interrupt you for 1 second.
Yeah.
And because your internet, you may not be aware, but you're kind of cutting in and out a little bit. People are...
I thought I saw that. Let me do
So,
one other thing.
That's okay. Kathy, Steve, could you the slide? Kathy, would you just reiterate that? What's the thing about the county health department?
Yes. Steve, if you could go back to the prior slide. Let's talk about the cleanest situation, which is when a child has a positive test. That positive test would come directly to the health department. We get that result via statewide lab repository for communicable diseases. And we reach out to the family, and that patient is put in isolation. And then we follow them daily to see what's happening with their symptoms, how are they doing, and if they're improving and they're fever-free for 24 hours, the minimum time that they're in isolation is 10 days. It can be longer than that if they continue to have symptoms and they're not doing well. Once we determine that they can be released from isolation, they will have a formal release with us. We can provide documentation if that's needed, a letter of some kind. We do that for employers all the time to say that you are now released from isolation and can return to normal activity.
Kathy, can I interrupt you with a couple of questions because there's some things
Sure.
in the chat? What happens if there's a child who has a positive test? The level of the school, what is the notification that the county health department does, and then what's the contact tracing? Can you comment on that, please?
Sure. Once we know that there's a positive, and if that child was at school for any time that they were positive, or 2 days prior to symptoms, we reach out to the school to learn about what was the situation in the school. Was this student in one classroom? Were they in multiple classrooms? Can they tell, was everyone wearing masks all the time? Did they keep social distancing or physical distancing? Depending on what we find, there may be other repercussions of that positive case in terms of quarantine. So again, isolation is for those that have a positive test and are lab confirmed positive. Quarantine are for those that are exposed, or more recently the travelers, but I don't want to talk about the travelers today. But
it's okay, we won't ask you to.
No, don't, please don't.
Kathy, what about the time? What's the time typically? Because I think this is one of the things that, a child gets sent home, they get a test. What's usually that time before the health department like steps in if there's a positive test?
Yeah.
Helpful thing.
We typically, once we're notified of the positive, we are typically reaching out within 24 hours or less. The issue is when we're notified of the positive. If there is a delay in the testing, let's say a student is sick and they go home and the next day they get tested, but the test result isn't back for 4 or 5 days, we presume they're positive, but until it's lab confirmed, they're not really in formal isolation with orders. They have to stay home because they're sick. And so the delay in testing can make that problematic.
Thank you. I'll let you guys go on.
Okay, so that's the cleaner case where someone actually is a lab confirmed positive. But we expect that the vast majority are not going to be lab confirmed positives. Right now, our incidence and penetration in the community is quite low. I think forgive me, I think it's about 0.7% this week is our penetration or positive rate right now of tests. So we think that most of the kids that have symptoms that are COVID-like may not have COVID. And that's a more complicated assessment to how do they come back to school. Steve, do you want to walk through that or do you want me to keep going?
No, here, I'll start it and you can help me out.
Okay.
So one of the really hard parts with this, and hopefully you can hear me better, is what we will do if a kid is contacted. So if a kid is sick, you know, we don't want to interfere. Obviously, the guidance doesn't seem to specify what doctors need to do. I mean, you see your patients, treat them, and that can be in person, by phone, or by telemedicine. If COVID positive, you know, we go to the county. If COVID, the problem is, in the language from the state, any COVID symptoms for a child to return to school must have a negative COVID test. So whatever you think is going on with a child, sore throat, get a rapid strep, it's positive, treat the child, follow them, monitor them, allow them to return, but can't return if they have COVID symptoms without a negative COVID test. They also want documentation from the provider that, you know, we've seen the child and returned them. So as you can tell, this is going to be the really difficult part here. And if there's no reason to test the child, maybe it's complete allergies or something like that, we still are stuck with the fact that the COVID symptoms include a variety of symptoms that, according to the guidance from the state, they want a negative COVID test before a child returns.
So Steve, if I could jump in there for 1 second. That bit of information was made clear just really this week, at the end of last week, beginning of this week. And I just want people to know, like, if school was going back tomorrow, then that's how this stands. And it may still stand like this when they go back in September, but we have a window of time. And I just want to say that collectively, as a region, all the healthcare systems and our various organizations are advocating to the state, first of all, for clarity around that documentation, because we recognize that for every child to get a COVID test is going to be difficult. And the more that we overwhelm the system, the longer it will take to get tests back. So I just want people to know we recognize that it's not ideal. But at the same time, we are going to work really hard to up our testing capacity as much as we possibly can. So I think that this is what it is right now. And if there's change in this, I mean, even to the point where if you couldn't get a COVID test, but you isolated a kid for 10 days, they were asymptomatic, you assessed and felt they could go back in, and they had the appropriate period of isolation, we hope that we can be able to move forward into that type of mode, but we cannot do that right now based on the guidance.
Yeah, and Kat, do you want to clarify what that would be? It is 24 hours fever-free. I'm trying to think of
well, when someone has an exposure, that 14 days kicks in, and that is the most conservative to have them come back. So that's where we're at right now. So what the state has said, and I'm going to quote from them, and I want to reiterate, I'm your local health department, not the state health department.
Right.
And I want to reinforce what Laura's saying. Although today these are what the state is saying, the state has in the past, when there was a groundswell for nursing homes where we were having to test workers twice a week and it overwhelmed the system, they went back to once a week.
Right.
So they do have a track record of listening when things don't work as well as they'd hoped. Anyway, the direct quote from the state, unfortunately, right now is that this returning to learning protocol after someone goes home sick with COVID symptoms must include a minimum documentation from a healthcare provider evaluation, a negative COVID test, and systems resolution. We're suggesting that time period is a 14-day time period, and that's because that's the incubation period for the virus right now, and the exposure right now for the asymptomatics is unknown. So that 14 days would give you both a time frame plus that negative test, and then they could return.
So I'm watching the chat, and obviously the questions are flying in. Are
Yeah.
they questions that exploded in a meeting that we had on Monday? So Brenda, do you want to step in?
Yeah, I just wanted to, again, hopefully have a little optimism here that I do think we're hearing from the state, you know, as we're reaching out to different representatives, we are hearing that there is room for clinical judgment. And I'm seeing a little bit from the chat about, you know, it's almost like an existential question, what are symptoms of COVID? That we do have some leeway here, that if you know the child, you know, they had a stomach ache for a few hours one morning, they don't need a COVID test to go back to school. They're totally better. So I feel very comfortable saying that there will be some level of clinical judgment, but I think we also need to recognize that we are still learning exactly the full presentation of COVID in children. So we also need to exercise some level of caution there. That's it.
Yeah, so I pulled up one of the screening sheets. This has the symptoms on it. I was trying to find another. What is listed on the CDC COVID symptoms includes fever, and the state is using fever as 100, not 100.4.
The symptoms of COVID. Well, we really don't know what the symptoms of COVID are.
Cough, short breath, rash, nasal congestion, rhinorrhea, sore throat, nausea, vomiting, diarrhea, new loss of taste of sense, loss of taste, loss of smell, fatigue, headache, myalgias, poor feeding, or appetite. So it's a huge number of symptoms. Again, what we're stuck with at this time. But as LJ said, we're not opening this week. We have time, and we're trying to advocate internally and externally to the state to allow more reasonable approach here. I mean, if you have a child who has known history of allergies, wasn't taking their allergy medicine, stays home for a day, gets back on their medicine, sneezing, nasal congestion, sore throat goes away, no fever, you know, they can return. Or a kid gets an obvious diagnosis of strep and is improving, can they go back when you feel they've resolved from their strep? So there are some scenarios where we can probably feel more certain, and there's others where we won't, but we need to have some ability to adjust this. So I just want to see where we had left here. Positive for kids, symptoms. School screening. I've been seeing some documents from schools as well. There is the whole discussion of temperature checks and whether schools may really do that or not, or rely on the parent. They have some screening documents that they're trying to use. Some schools are even suggesting they reach out to the parents and try to set up a behavior contract, like we will check our kids for symptoms. We will not send our kid to school sick, which I think we have to try to emphasize extensively. How the schools are also checking their staff is important, because that is probably a little bit easier, but it's going to result in some of the same questions. If there's a sick teacher or staff member, then whoever's in contact with them has to go down the contact tracing route as well. A number of schools are using web-based apps, Dr. Chatbot type tools, or Rock COVID, if you've seen that. Some schools have actually made their own app or survey and essentially going through the screening questions. And this next slide here actually is an example of one that has, what are the symptoms that are on here, temperature, how long you're working, and then also more recently including, contact, noticeable contact or exposure to COVID, or if they've traveled. A number of the schools are concerned about that because they have staff and faculty who've gone on vacation somewhere. Is a hot zone and they will have to isolate for 2 weeks. So that's probably one of the last questions on here. Kathy, anything else on this?
No, I think you covered it really well. And, I think we are, I can't say that we're hopeful that the state will become more flexible for clinical judgment. We need to share with where they're at today. But they did at least once change one of the guidelines that they had when there was a groundswell of support, that it just didn't make sense.
Right, and we're seeing that, and we're trying to advocate for that internally. Now masks, which may be the other fun question of the night that everyone's asking. So essentially, every school I've talked to, plans I've seen, they're requiring masks for all kids, all students, all visitors in the building at all times. Some are a little less specific about it, but they're trying to require it, essentially on the bus, when they're in transit, in between classrooms, in the classroom. There is the 6 feet or masking, but a lot of schools, it looks like the language we're trying to do is 6 feet and masking. With that said, we approached Mike Mendoza about this, and we looked at it from the same standpoint as the vaccine exemption. It really needs to be a true medical exemption, not personal philosophical. And we've reached out through the AAP and other groups to different subspecialists. What are the medical questions or behavioral issues and stuff? And it really comes down to really a few categories. And so this document here we have next is maybe not the full final one, but essentially a document that schools are requiring, or that the county, Monroe County is offering to then provide schools. And this is really what schools want.
Steve, this is based on the vaccine exemption form. So the format may look familiar to some of you. For those rare instances where someone has a medical exemption to a vaccine, this is the state form that's used. So we've adapted it to Monroe County and instead put in the draft criteria for what would be a reasonable.
Not good for social workers, so now we got to deal with.
Everyone mute, please. Thank you.
So we've tried to keep it as narrow as possible in terms of what would be a true medical exemption for a face mask.
Right.
And so this may not be final, but this is the working document.
Right. I mean, so really kind of very significant, neurologically impaired children who can't remove a mask themselves. A lot of our significant special ed kids really falling into that category. Children with previously diagnosed severe developmental problems who may have significant, sensory issues, aggression potentially, as well as children with serious emotional disturbance or other significant mental health issues where applying a mask might actually make symptoms worse. Now, one of the things in this that we discussed actually with Susan Hyman and some others is don't think of it just as a blanket statement, especially for the second two, because a lot of the special ed community, occupational therapists in our region have been working with kids who are on the spectrum, who have sensation issues, and conditioning them and getting them used to wearing masks. And they are posting videos and tools and getting them out to schools, showing them how to do that. So we probably don't want to think of this really so much as, all right, well, they get an exemption for the year. It's really should be tied to something saying, and they should work with a counselor or therapist to work on conditioning. And the reality is that most of these kids are probably in the care of and should be in the care of a specialist that might be the one actually signing this. So that's something that we're trying to also nail down to to really touch on those specifics, because I think everything we're seeing in the literature is, children who have a lot of medical complexity may actually be at higher risk in some cases for contracting infection, and may actually need to be doing more remote learning as opposed to being at school without a mask. Now, again, the children with trachs, technology dependent, those are a additional set of issues, and schools are looking at providing those teachers and staff with additional PPE for them, N95, suctions, gowns, everything, so that, if they have to help that child, that they will have as much equipment available and still try to, whether it's tent or provide some type of covering for that child, that being the goal. So again, this is what we're looking at.
I'm glad that you highlighted that. I'm interrupting for 1 second because there were a lot of questions in the chat, like what happens if a child's mask exempt? Are they in with a classroom of kids who are wearing masks? And then what's the risk? This really is a unique population.
Right.
Who would be cohorted, or, I think we're trying to avoid remote learning in those situations, but
right.
So
they would be more distant as much as possible.
Yes. Mm-hmm.
Okay.
Yeah, I think key is that we want to create what's going to be safe for everyone. And there may be some customization of that by district of what they can provide for these kids. But key to that is a very high level of PPE for the staff if they're interacting with them, and probably a different type of cohorting and distancing, and possibly different types of transportation. You may not be able to you may have different buses for them, for example.
There was a question about busing in the chat right there about what is the issue, what is the plan for busing? Is it 50% capacity, or is it 6 foot and masking?
It's definitely going to be masking. It's probably going to be 6 feet, except if it's a household contact, so siblings could sit in the same seat. And then depending, again, they're trying to get as much wiggle room around that, where if they can put a kid, if they think of a seat as 2 seats, they could put a kid in each row as long as they're far enough apart, and then there's space in between. So it's probably going to be close to like 50% capacity. Schools are also looking at, can they put additional shielding in and try to get more capacity out of it that way? But definitely masking is something that they're all seeing that they have to do on all of them. The special ed kids are going to be, obviously in an added challenge to this. If they have an aide, if they have someone with them, they may actually be able to, tolerate having, some type of mask or covering for a period of time. But again, it's really going to be a limited set of kids. I'm trying to think if there's anything else here.
Steve, I wasn't laughing at what you were saying. I just read the chat, and Louis, thank you for saying that. I also have been feeling like I've been coming down with COVID, because this whole thing is a headache and makes you feel sick to your stomach, because it just doesn't feel like we are in the place we want to be. I just want to highlight a few things from the chat, and then actually we're going to open it up so you guys can speak and not have to be in the chat. I think here, I'll just give my opinion. The deal is, we do this right. We don't want these schools to get shut down, right? We want to set the stage so that more schools can open, so that our CSD kids can go back to have some in-person education. And if I had a magic wand, if we all had a magic wand, poof, we would have PCR testing galore. We would have enough testing to do everything that we should. And I will say, the conversations that are going on around the community, both within the 2 hospital systems that do testing, and with, I give credit for our acute kids urgent care, looking to advance the platform and availability for PCR testing, that's happening. That's really being thought about right now. And that answers, I saw Dave Sulo's comment, we have to be careful about how much wiggle room, and I think Dave Topa, you were the other person who was in there, we have to be careful about just how much wiggle room there is, because you can use your clinical judgment to a certain extent, but this is COVID in kids, and we don't know exactly what that will look like for every kid. So the ability to test is really important. What we don't want to have is a requirement for testing to have a negative test to go back to school if we have a child who has completed 10 to 14 days worth of isolation for their symptoms, and is asymptomatic, which would be exactly what you would do for a positive test. So in my mind, that is the biggest part of advocacy that we can do, is to have some leeway for those kids. But when you weigh the risk benefit, it's not fun to think that your own child would have to be out of school for 10 days because they had a cold and somebody couldn't confirm it wasn't COVID. But if it means the whole school doesn't shut down because some other kid was pulled out appropriately who did, I think we have to be mindful of what we're really trying to do. And so I hope in the conversation that happens, that goes on from here, I recognize this notion of the burden for practices, the need for more PPE, how you're going to answer all these questions. Wow, that was my dog, scared me half to death. I think that we want to hear what your worries are right now. This is not meant to be just a venting session, but like, let's really talk about what your worries are, and let's think about how we can support the practices as best we can. And all of the experts are here on this call. So why don't people like voice their questions? You can still put things in the chat if you're shy, but I think it'd be better to hear from you.
Just hit *6 to unmute yourself, folks.
I'll go ahead and start. One of the questions I just want clarified was, if a child is seen in the office and has a positive strep test, am I still understanding correctly that they cannot return to school until they are 10 days symptom-free and have a COVID negative test, even though they've been treated for strep?
Kathy or Brenda, do you want to take that?
I'll take it.
So I think the,
Okay.
oh,
Well,
go
unless
ahead,
you want
Kathy.
to. Either way, it's not going to be the answer that we all think is the right one. But right now, the answer that we have for that is yes, they will need to stay home because people can have strep and COVID. And what the state is saying is that if they have COVID symptoms, at this time they have to be home, they have to get a negative test, they have to have an evaluation.
So if they have a negative test that returns within 10 days, if they have a negative test performed here locally, they can go back to school with that negative test. They don't also need to stay out the 10 days. The 10 days is for a positive test. You still need to stay out 10 days, even if your symptoms, at least 10 days, even if your symptoms resolve in 24 hours. But yeah, for a negative test, the sticking point is that, particularly with other viral infections, and we've had a lot of discussion locally about how would we handle positive streps, but that there's always a possibility of co-infection and more than one thing going on. So that's why the state has not yet said specifically, well, if you have another known infectious process that explains it, that you do not need to test for COVID. We haven't gotten that from them yet. But if you can test for COVID, it's negative, they can go back.
Let me talk just a little bit about what quarantine means, though, because that's not a 10-day process.
Yep.
If someone is exposed, a known exposure, that is a 14-day incubation period, even if there is a negative test, say at day 5. They still can't come back until the incubation period has totally cleared, when the status is quarantine.
Yeah, so the Kathy and the health department have two distinctions. If you've been exposed to COVID and you're designated by the health department as a close contact, exposed person, you're out on quarantine waiting to see, so you're seemingly well, waiting to see if you then develop infection. That takes 14 days. If you're sick, get tested, or you get tested for whatever reason, the test is positive, you need to stay out at least 10 days till you recover from that illness. And those are very distinct things. Quarantines for well and waiting, and isolation is for sick and recovering.
Sick or positive and asymptomatic.
Or positive, yeah.
And asymptomatic, yeah. So it's the key thing for isolation of that 10 days is a lab confirmed positive, whether they have
I have a
symptoms or
question.
not.
It's Galina speaking. Has there been any discussion between any of the health department or just the systems for is it possible to mandate the flu vaccine this year to enter public schools? Just because at this point, don't we want to decrease the likelihood of concurrent or tandem with COVID situations occurring?
There's been a lot of discussion of how we can increase the hype and the desire to have flu vaccine, but I have not heard anything from the state of mandating it. It is difficult enough for them to have the current state mandated vaccines for school. So I've not heard any discussion about mandating the flu vaccine, but we really welcome everyone to push it even more than normal. And there'll be a lot of outreach to the community, more than we've done in prior years. And I'm hoping a lot of communication, maybe a lot of free media on this, because you're right, the symptoms are so similar, it's just going to complicate everything. One nice thing, if everyone's wearing masks all the time, the flu rate in general may be down a little bit. We did find when the March, April time period came that our flu rates really plummeted. We typically have flu throughout the year. It's not just in the winter. But when everyone started masking, those rates really came down.
So what I'm hearing...
the Southern Hemisphere is showing that too, so.
What I'm hearing is even if we have a child present with COVID-like symptoms and we find an etiology like strep or positive flu, since they can have both that and COVID, we're screwed. Every kid's going to have to stay home for 10 days.
Or get a COVID test.
So now I'm
as it
getting
stands
chest pain
now.
besides nausea and a headache.
Right. So,
Yeah.
so people are asking, can we have an algorithm? There was an algorithm in progress until we learned this.
Yeah.
So I hope you will have an algorithm in 2 weeks, but we have to have some questions answered. And I think honestly, we all do better if we have more information. And so this is transparency time in terms of this is what we've got in front of us right now. And we need to do the best we can with it. And I think we have to be particularly public health minded. But we need more.
If I were to be
testing
able to get
capacity.
an antigen test in my office, even though it's not as sensitive as a PCR, that's not good enough.
No. And that question came up in the chat. I want to come back to it again. I think it was Janet. I'm not sure which Janet it was, but one of our pediatricians asked again, is that what the state is saying, that they would only accept PCR? That is our understanding. Am I right, Brenda, from the questions that we asked just in the last 2 days?
That's been the unofficial answer. We are asking these questions, so of course with everything there are appropriate channels, and that's what we're looking to get, the very official,
we need to get it in writing.
Answers from the appropriate person at the state health department. But that has been their answer. The antigen test, it has been recommended that a negative antigen test is followed by a PCR. CMS says they will not accept a test with less than 95% sensitivity as an official diagnostic COVID test. So I doubt the state will budge on that aspect of it. We're asking to see, but I wouldn't hold out for that.
Kathy, Zahik Assas, I'm calling from Wilesville. At the end of the 14 days quarantine, do you retest the exposure?
Or they go back to... let me go through quarantine a little bit more detail, because it is a little odd. So you don't need to retest at the end of quarantine. After 14 days, you have completed your incubation period and you're done if you're at close exposure.
So there's no chance of being a carrier or a positive but asymptomatic and spreading it at school?
I won't say there's no chance. What I'll say is if you are put in quarantine because you are a close contact, then you are in the incubation period from the last contact you had with the confirmed positive. Are there confirmed positive people walking around who are shedding all the time? I think we don't know that yet. We do know that people will test positive for, in some cases, for maybe 6 weeks, 7 weeks after the infection. but they are not infective. And Brenda, maybe you can help me out here, but I believe the literature that we've seen is that between day 9 and 10, the fragments of the RNA that are shed are no longer replicatable. And that's good news.
Yeah, so if we're talking about,
did I say that right?
Yeah, people
So
who are infected, yeah, otherwise, outside of maybe severely critically ill in the ICU and severely immunocompromised, after 9 to 10 days, any nucleic acid that's detected, they haven't been able to culture live virus. So that's kind of the first step to then say, is there live virus, to hint that it could be transmissible, and then is there even enough of it to actually spread it to anyone? And they haven't even been able to get past that first step of finding live virus that you're able to culture after 10 days. So that's why initially, timing wise, it was easier because initially both 14 days was for both quarantine, which is you've been exposed and you're healthy, and isolation, which is, you're infected. Both of them were 14 days. They shortened that to 10 days because of this, but you do also want to have the symptom resolution.
And when someone is placed, oh, go ahead. I was
No,
going to
just because I'm getting people firing questions at me in the chat and otherwise. The 10 days and COVID test. Can we just clarify that is it 10 days and COVID test negative? Or if they have a COVID test negative, they can go back before the 10 days?
Yeah.
I just want to make sure we state that openly. That it's 10
Yeah.
or COVID negative.
Yeah, I think as it stands now, COVID testing is like at the top of your pathway. If you're COVID positive, 10 days and symptom resolution, health department is telling the school that kid can go back. COVID
Brenda,
negative, go back when whatever illness, as if we're not in COVID times, and how you would treat that and send the kid back to school. Is that right, Kathy? Or
well, the test is correct. You have to have a negative test. The days is not actually specified at this time for the non-close contact. So I don't want to say it's absolutely 10.
Well, yeah, I don't think we're talking about exposure. We're just talking about a kid who's sick and gets sent home from school.
Mm-hmm.
Right.
To go back to school, if you're ill for some reason, to go back to school, or on this pathway of COVID test, if it's positive, then it's a time-based thing, and the health department will say when that kid is going back to school, not the child's provider. And then if the test is negative, it's just as if you would counsel a family.
I may have missed it. So if we get a kid who's positive, his siblings have to quarantine for 14 days too?
Not necessarily. That is a process of, when you've heard the term contact tracing, we do a very in-depth interview of the exposure. So if the siblings were unmasked and in close contact within 6 feet for more than 15 contiguous minutes, they may be put in quarantine. If they were not, they might not. So it kind of depends on the family situation. Was all the kids in that house the whole time? Is there shared custody? We do a fair amount of in-depth, what was the actual exposures like? So the younger the kids, the more likely that the parents will have quarantine because they are in far more close contact. If you've got a couple teenagers that don't ever interact with each other, we ask those questions.
There are a series of questions in the chat about what if someone refuses to test? What happens in that? What if a parent refuses to test? What happens in that scenario?
I don't think we have an answer for that right now, except for what the state is saying is that they can't return without a negative test. To me, that's something that I'm hoping the state changes.
Right.
But I can't go outside the guidelines of what we've got in writing from the state right now.
Exactly. We're hoping the state will say, if we treat them as if they are positive,
yes,
is that as good as having a negative test? Just put them in that positive category.
Even
but-
make them a positive and a quarantine. Give them a whole 14 days and let them come back.
Right.
To me,
Yeah.
that would be a good compromise, but we don't
Yeah.
have that from the state yet. I wish we did. I hope in 2 weeks we do. But right now, that's not what we have in writing from them.
Yeah, maybe just to reiterate for Ed, I mean, think of it if, you know, if it's a negative, if it's a kid who's doesn't have COVID, negative test, a letter from us saying they're clear, symptoms improved, and fever-free 24 hours. Now, you know, and so whatever their diagnosis is, if it's strep and it includes that, or RSV, or, you know, whatever, those are like the three main parameters.
Yeah, so it's extra work for us. I'm just thinking about, you know, the 7-year-old kid who's got 2 or 3 siblings. No one's wearing a mask 24/7. So those 3 siblings are going to have to stay out of school for whatever the quarantine is decided.
Yeah.
And we may as well just close schools now. I mean, this is the only thing that I can hope for, is that the infection rate is so low that we don't see any COVID-19. I mean, other than that, one case and I'm just, and I think everybody's sentiment is the same, and it's nothing that we can, and I know LJ didn't want this to be a gripe session, but this is like a no-win situation for those of us in primary care.
We still have time though, Ed, and that's where I think key is, we, you know, advocating internally, externally as best we can, providing what these scenarios are, providing the examples of what could go sideways on this. You know, when you have to start testing that many times and what your backlog becomes, because my sense from other communities is that they're not turning around tests even as quick as we are. So I think, not that it's great or is it going to be easier on us, but other communities may run into this problem even faster than we are. And that, you know, lots of people around this generating this complaint is what may help us.
Is there a protocol?
Sorry.
Is there a protocol as far as schools goes, whether if there is a positive in the classroom, so is that automatic that it's just going to be like there's a positive, or is the identification going to occur, or sort of is there at least any thought of what that's going to look like?
So the discussion so far on that is, if there's a positive case in a classroom, is that classroom may be quarantined initially, to give us at least 24, they'll be asked to be quarantined for the next 24 hours while we sort out the contact investigation piece of what is the spacing like, what was the exposure like, what was the mask use like. So not an automatic shut down the school, but it might shut down that classroom. That's not in stone yet, but that's the thinking right now. Just to give us the time to double check of, you know, were they wearing masks? Was the teacher wearing masks? And what was the spacing like?
So I have a question for Kathy. So are you suggesting that before the school year starts, the entire household kind of goes in somewhat self-restrained isolation from each other? Like,
No.
it would be the same thing for the college students if they're living in rental houses and they're all eating dinner together, and if one catches it, everybody goes in the quarantine. But if they are 6 feet apart at all times, then they are not going to be subject to that quarantine.
So let's talk about families first. We don't recommend that they stay separate if there's not an infected individual there. And even in the case of newborns and their moms, we recommend that they continue to breastfeed. We may, if mom is positive, we suggest that she mask. But no, we don't want families to not be together. They're almost, you may have heard the term of, there's bubbles of where you have interaction, but you don't expand your bubble. So that if the unfortunate event happens that one person is infected, yes, probably the whole bubble will be put in quarantine, because about 50% of our infection appears to happen within households, or at least that was true until about 2 weeks ago. Now that we're getting college students back, that may change. But no, we're not expecting families to quarantine from each other when there's no positive case there. We have a very low incidence in this community right now, and that's because of the hard work of what all of you guys have done to keep the community safe. College students, we're learning. If you're asking me personally, if I've got congregate living of college students living together, are we asking them to quarantine? I think that would be not realistic. I have a college student. I can't hear you now. Are you on mute?
Yes, me too. I have a college student. He's in a rental house.
So, but I think as smart as we can get them about what the risks are and what happens if they get exposed, we may be able to moderate their behavior a little, but.
So I have kids going into middle school and high school. If I have a kid who comes home and is positive with COVID, that means I cannot work for 10 days, 14 days.
That's an interesting point. If you are in quarantine, but you're considered an essential worker by your employer, you can still go to work as long as you mask, you take your temperature twice a day and check for symptoms. So as an essential worker, yes, you can go to work, but you should not be going out and about unnecessarily. So grocery shopping, socializing, all that. But yes, quarantine workers that are quarantined and considered essential can go to work. That's from a county perspective. Your employer may be stricter on that point. But from a county perspective of quarantine, that's allowed.
Thank you.
Kathy, what happens to the other student when a student is sent home sick with a fever? Do they stay in the classroom while waiting for 3 days for that test to come back? Or do we quarantine the classroom?
I think we're working through that with each district. Probably what we're recommending to districts is they try to cohort their students. So let's say someone is sent home sick and they're in a part of a classroom that has 12 students in it. They probably aren't going to send all 12 students home right at that moment, partly because of transportation. So they'll keep them in their bubble, and then we figure out at the end of the day how they get home. But I think all the logistics are not yet worked out. The plans were just recently submitted, and we are meeting very regularly with the superintendents, and then that will trickle down to each district.
So the school will be calling you with every sick child, so you decide what to do with the class?
That would surprise me, but the child, if there's a positive case, yes, we will know about every positive case. I don't think we're going to know about every sick kid that has a stomach flu that gets sent home, because we're not going to quarantine that class. That's not a lab confirmed case. It's when we have a lab confirmed case that we get very more careful about how those students are handled.
So while waiting for the result on that index case, the students still go back to their classroom?
They would stay within their bubble. And I think, to be honest, I don't think we've worked all of that out yet with each district.
Thank you.
I have a question. Oh, sorry.
No, I'm sorry.
How about Ed Lewis first? Because I know you from a long time ago, and it's good to see you. Wait, now I can't hear you.
We lost you, Ed.
Oh, wow. Come back.
COVID hotline is pretty involved in, and you don't get to talk to anybody.
I'm sorry, you broke up. I didn't hear the whole question.
Oh, okay. I'm sorry. I don't know whose line is where it's coming from. Will we have a dedicated resource to be able to call when we have questions, which I see happening at least 10 times a day? Because trying to get through to the COVID hotline, you get somebody who's answering it. If you can get somebody who's answering it, then they have to refer to somebody else. So we're really going to need to have somebody we can talk to.
So I think what I heard the question to be is will there be a dedicated line for physicians to, yeah, but I think I got the gist of it. Will there be a dedicated line for physicians to call when they have questions?
Yeah.
And at this time, we don't have a separate line. It is the COVID hotline. And that is probably more along the lines of leaving a message and having us call back. And I know that that is not sufficient at this time, but that is what we have in terms of phone line that doesn't have blockage.
Kathy, is that something that maybe we could look at? I've been starting to write down some of your comments in the chats and some of the things that you've said, and I've got some sort of action items for us to consider. And was that question of, could there be some type of a hotline specifically for primary care providers around some of the questions that are going to come up with kids in school, to be able to get the health department's read on stuff, or to have a consult from infection prevention or epidemiology? I mean, is there a way for us to think about that? Because the only way we're going to be able to have some alignment and not have people doing all kinds of sort of guesstimates or workarounds or having things be inconsistent is if we have that backup. So I think that that's a question that we should talk about this week and think about a system for that. Some of the other things you guys have mentioned, because I realize our time is getting towards the end here, and there's still a lot of questions that weren't addressed in the chat. We may have to go back and sort of capture those and do some type of mailing back to everyone. But a decision tree, I know that people want a decision tree. We wanted to have a decision tree to show people tonight. We don't have that yet. I hope we will have some kind of a decent decision tree in the next 2 weeks. And so if it means I think we probably would call another meeting like this and do a distribution. I think that we will have to do that. It doesn't have to be this long, but we will try to update everyone before schools are going back, what information we have. The other things that people talked about in the chat, we're having some regular information that goes out from infectious disease about what are the common things that are in the community. We've had that in the past. There is something like that, I think, available on the website, but could we do something, Brenda, with PEDS ID potentially, to be able to broadcast that out? That at least would help people to know what's in the community, I think would be great.
Yeah, definitely. We've talked about that a lot, kind of the reincarnation of Karen Hall's work. Yeah, I can talk with our microbiology lab. We had them, and it is publicly available on our microbiology, our clinical, the URMC Department of Pathology Clinical Microbiology website. They do respiratory viral tracking when it's in season. So let me talk with them. They obviously have been extremely short-staffed and spread thinly through this. The other thing is the county level COVID testing. So maybe something that even kind of brings that in together.
Thank you. Yeah, some kind of reporting piece, I think, to keep everybody on the same page and up to date for the region would be great. I think there were other comments about the hotline, that maybe it's not a hotline, maybe it's a website where primary care providers could enter their credentials and it would get at least a faster response because it would be highlighted as such. So Kathy, again, maybe we can talk and think about that after. Advocating for insurers to continue telemedicine coverage, doing that all the time, every day, and that needs to continue.
That actually, actually with Trump signing that for CMS, for Medicare, it's now also been offered by CMS, and it's open comment for like another 30 days, which bodes really well for it to stay. So that's another advocacy piece, but that is a positive thing that came out fairly recently.
Yeah, and the question that's in the chat there is, can't do telemed if everybody needs a swab. That is true, but there are some ways to potentially, you all did it during the pandemic. I hate to think about it, but you did some telemed stuff and then you sent somebody out to swab the kid at the car for strep or other things. And my worry for all of you is what this will do to overwhelming the capacity of the office, not only the phone triage and the nurses, but actually having so many kids come into the office, and what does it mean for PPE? So one of the things we're talking about, and I would appreciate, you can throw it in the chat because we can't capture everybody's questions, I think, in the 3 minutes remaining, but I think we do need to think about ways to be able to get testing done or to have you have a referral base to have testing done if you don't have the capacity or the space to see those kids in your office. And I know that, urgent care for primary care. I'm sorry for the acute kids people who are on the call, but urgent care to primary care doctors is sort of it's something that we don't always love, but when it's on a referral basis, when it can be done where it complements practice and is not competitive to practice, that's a wonderful thing. So thinking about where we could have places like that you would be able to refer to both acute kids and the independent urgent cares have done a great job with that, as have our system urgent cares. So I am seeing more in the chat, but Chad, are you reading this? Can you respond? Because I can't keep up as fast.
Yeah, I think a lot of this we're just going to have to kind of respond to and maybe send out general responses. I mean, the questions are coming pretty fast and furious, but a lot of it is, can we have drive-up testing? Can we have the school system swab? All of those things have been discussed and are being considered, but as you can imagine, there's logistics with all of them. So there is no one perfect answer, and I think just as fast as we could set one of these logistic things up, we could have a change in recommendations from the governor's office that undermines the need for everybody to get COVID swab and obviate all of the logistic planning. So I think there's going to be a lot of change in the next couple of weeks as we get closer to the go back to school day.
So I think we got a lot of work to do together, and our kids deserve it, that we do it the best we can. This is totally an imperfect situation. And we need to make it work if we can. And we will support you guys in that. I mean, I feel like I know almost all of you on this call now. And so you can send your emails our way. We read them. We'll think about your ideas and your thoughts and your needs in this. And I would just recommend we set up a follow-up meeting, potentially 2 weeks from now, so that we're catching you guys with a little bit of lead time before school starts and update. And if there are significant updates that come in the meantime, we can share those throughout all of the systems that are represented on this call. We can share those through email. I hope that
we can do an FAQ from this.
Yeah, we will do an FAQ from this, and there is a recording. We can share the recording. We'll work with RRH's system and the GRIPA, as well as URMC, AHP, and then for the other practices. The last thing I just want to say is the work that we all do together is not just about testing, right, and diagnosing. We do a tremendous amount of behavioral health and emotional support for kids and families. And so that work we really need to figure out too. And I think we'll have great opportunities to collaborate. So I just wanted to give a shout out to all of the behavioral health providers and care managers on the call who are ready to help support your practices. I guess that's it. It's 8:30. I don't know what else to say that could be positive, but I am glad to be in Rochester. That's the one thing I will say. I'd rather work with you all than any place else. And let's put our heads together and roll up our sleeves and figure it out. Okay?
Laura, thank you for pulling it all together. I really think this was a tremendous reflection on this community, that we can all come together and talk about difficult issues that are not perfect and see what's the best we can do with what we've got for our kids and for our community. I mean, I just think this is outstanding.
And we'll steadily get better. That's the goal.
Mm-hmm.
Everybody, really appreciate your time. We'll sign off. Send your emails.